The following instructions overview the pump and catheter implant procedure for the Medtronic SynchroMed 2 programmable infusion system. The SynchroMed 2 infusion system may be implanted under general, regional, or local anesthesia with sedation. To implant the pump, you will need these supplies: a SynchroMed 2 pump, a Medtronic intrathecal catheter, a catheter passer, and the Medtronic Envision programmer. In addition, have a C-arm fluoroscope available. The pump is prepared once the catheter is placed in the intrathecal space. Please consult the pump preparation segment of this program for supplies and procedures needed to prepare the SynchroMed 2 pump. The position of the pump pocket should be determined before surgery. The pump is implanted subcutaneously, usually in the lower right or left abdomen, away from the superior iliac crest and rib cage.
When considering where to put the pump pocket, a couple of things need to be thought of. I tend to pick the left side first, just for the idea that if a patient ever needs a surgery on his abdomen, it's either going to be the gallbladder or the appendix, which are on the patient's right side. I think other considerations are obvious. If they've had any other surgery, where are those incisions? If they have a gastrostomy tube, a colostomy, some other surgical scar or implement on their abdomen, you have to adapt to that. Other considerations, where men wear their belts lower, women wear their belts higher. They don't want their belts rubbing against it. My first choice, again, is on the left side and just below the abdomen, and tend to put it down in the left lower quadrant. But I will vary from that based on other considerations.
Once the best position for the pocket has been determined, mark it clearly on the patient's skin with a marker. The use of prophylactic antibiotic treatment for the patient may also be considered. To begin, place the patient in a lateral position with the lumbar region slightly flexed. The side where the pump will be placed should be up from the table, and the patient's back should be perpendicular to the floor. A baseline fluoroscopy image should be taken to confirm proper positioning. Prep axilla to pubis, table to table, and drape the area widely, leaving both the pump and catheter insertion sites exposed. Cover the skin with a plastic surgical drape. The next step is to place the catheter. Use fluoroscopy to identify the intraspinous intervals in the lower mid-lumbar region. A paramedian oblique needle insertion technique is recommended.
The shallow angle oblique approach is essential in preventing complications of the catheter being sheared that occurs with a midline approach. The use of fluoroscopy is essential in positioning the needle. It allows you to place the needle very precisely without having to make multiple punctures. It also allows you to use the shallow angle oblique technique. L4-5 and L5-S1 have the greatest motion, so we preferentially try to place the needle at L2-3. Go from the L3 pedicle up to the base of the next higher level.
Using fluoroscopy,
insert the 16 T-gauge introducer needle and stylet with the beveled needle tip oriented parallel to the longitudinal dural fibers. Advance the needle until the dura is penetrated. Remove the needle stylet and confirm the position and placement of the needle under fluoroscopy. The imaging target for the needle tip is the midline of the selected interlaminar space. Observe cerebrospinal fluid backflow and then replace the stylet to prevent CSF loss. Before introducing the catheter, verify the bevel of the needle has a cephalad orientation, making sure the key of the stylet cap and the orientation indicator on the needle hub faces up. Then, remove the stylet and confirm the catheter is fully inserted within the channel of the guidewire handle. Thread the spinal segment of the catheter through the needle to the desired vertebral level. Expect a slight increase in pressure when the tip of the catheter reaches the curved point of the spinal needle. If you encounter any resistance in advancing the catheter, try to reposition the patient, rotate the needle slightly, or change the needle depth or angle. If the catheter must be retracted during positioning, do not withdraw the catheter through the introducer needle. The needle tip can damage the catheter. Withdraw the introducer needle and catheter together. Then, carefully retract the catheter from the introducer needle and begin the procedure again. Do not pull back on the catheter with the spinal needle in place. Pulling the catheter back could lacerate or shear off the catheter in the intrathecal space. Confirm the position of the catheter tip with fluoroscopy. With the needle still in place to protect the catheter, prepare the anchor site by making an incision that exposes the lumbodorsal fascia. The incision should be long enough to permit placement of the anchor, and in some instances, the catheter connection, without introducing kinks or sharp bends into the system. Using heavy, non-absorbable suture thread, place 2 tie-down sutures adjacent to and on opposite sides of the needle entry point. Place a purse string suture on the fascia around the catheter, but do not close the fascia at this time. Carefully remove the needle from the fascia. Then, grasp the catheter near the exit site, and carefully slide the needle to the guide wire handle until the needle hub touches the guide wire handle. While still holding the catheter securely at the fascia exit site, slowly withdraw the needle and guide wire simultaneously. This prevents the needle tip from damaging the catheter during guide wire removal. After confirming CSF flow, use rubber-tipped forceps to clamp the end of the catheter to the drape above the incision site to prevent CSF loss. Locate the anchor dispenser and attached anchor. Unclamp the spinal segment of the catheter and thread the catheter into the metal tip of the anchor dispenser until the catheter exits through the dispenser slot. Using rubber-tipped forceps, reclamp the spinal connector end of the catheter spinal segment to prevent CSF loss. With one hand, grasp a portion of the catheter that exited the anchor dispenser, and with the other hand, use the dispenser to gently slide the anchor towards the fascia entry point. Continue until the leading end of the anchor touches the fascia entry point. Push on the top ridge of the dispenser handles until the leading edges of the anchor wings touch the fascia. Note that you should not dispense the anchor at this point, as the anchor cannot be repositioned once it has been released by the anchor dispenser. Use tie-down sutures to attach the anchor securely to the surrounding fascia. Then confirm the catheter tip location using fluoroscopy. Position your fingers and thumb on the anchor dispenser, similar to holding a syringe, and release the anchor by using your fingers to pull the dispenser handle towards your thumb. Unclamp the catheter and grasp it near the anchor. Use your other hand to gently slide the dispenser off the end of the catheter. Confirm CSF backflow, and then reclamp the catheter to prevent CSF loss. Pull the purse string suture ends to close the fascia around the catheter.
I think the fact that it embeds deep into the fascial tissues and allows the sutures to be tied on either side of the catheter, that is a good thing. In the old V-wing anchor, we were tying sutures very close to the catheter. The needle was very close to the catheter. With the new anchor, I think we can more easily keep the needle tip away from the catheter during the anchoring process. And the deployment device sets the anchor in a firm location, so it takes a little bit of the guesswork out of it.
The next step is to prepare the pump pocket. Make an incision following the preoperative pump pocket markings. The incision should not overlay the final position of the pump. Because fibrous bands in the pocket can be vascular, meticulously use electrocautery to avoid hematoma or seroma after surgery. When finished, the pocket should be no more than 2.5 centimeters beneath the skin and large enough to easily accommodate the pump, allowing a gradual curve of the catheter. Tunnel subcutaneously from the spinal incision to the pump implant site using the Medtronic catheter passer. Pass the pump catheter segment from the pump pocket to the spinal incision. Note, depending on the catheter model being used, you may tunnel the catheter in the opposite direction.
You guys have this really nice tunneling device that is easy to use, very malleable, and I use that almost on every tunneling case. And if I'm going from the spinal site to the pocket in the abdomen, I try to make one tunnel rather than bring the device out through a separate incision. And in most people, the tunneler is so malleable that I can thread it from the spine all the way to the pocket with one pass. And what that does is it prevents me from having to make a separate incision, which of course introduces pain and a new sort of site of a potential infection and so on. So I'd rather not make two tunnels. And most of the time I can do that. I actually reach into the pocket and try to feel the tip of the tunneler as it's pushing through, and try to guide it from the spine to the pocket with a two-handed technique.
Next, connect the two catheter segments. Note, if you're using a model 8780 catheter, you will only have one segment of the catheter to connect. To connect the catheter segments, locate the catheter connector and grasp the center of the connector. Insert the end of the pump segment into the hole of one of the collets. When doing this, the pump segment will slide onto a metal pin in the center of the catheter connector. Continue inserting the pump segment until you see the end of the pump segment past the collet, and the catheter will not insert any farther. Unclamp the catheter and trim the clamped or excess length of the catheter spinal segment as necessary, leaving at least 5 centimeters outside the fascia entry point to permit catheter connection and to allow slack for patient movement. Save all pieces of trimmed catheter tubing to perform length measurements and volume calculations at the end of the procedure. Confirm CSF backflow. Then, grasp the center of the catheter connector and insert the end of the spinal segment into the hole of the open collet. Continue inserting the spinal segment until you see the end of the catheter past the collet, and the catheter will not insert any farther. Firmly grasp the collet that is over the spinal segment, and with the fingers of the other hand, grasp the tapered portion of the collet that is over the inserted pump segment. Push the pump segment collet towards the center of the catheter connector until you hear and feel the collet click into place. Maintain a firm hold on the collet that is over the spinal segment and tug on the pump segment to check that it is firmly attached to the catheter connector. Firmly grasp the collet that is over the pump segment, and with the fingers of the other hand, grasp the tapered portion of the collet that is over the inserted spinal segment. Push the spinal segment collet towards the center of the catheter connector until you hear and feel the collet click into place. Maintain a firm hold on the collet that is over the pump segment and tug on the spinal segment to check that it is firmly attached to the catheter connector. Double-check the catheter segments to ensure they are securely connected by pulling the two collets in opposite directions at the same time. The collet should not move back and forth or rotate and should feel firmly attached. Also, gently pull on the catheter segments at the same time. The catheter segment should not detach. Verify catheter patency by observing CSF backflow at the pump pocket site. At this point in the procedure, make sure that the pump has been properly prepared and is ready for implantation. The pump should have been interrogated to confirm pump function, emptied, filled with the prescribed drug, and flushed with sterile saline at the catheter access port. To connect the catheter to the pump, grasp the tapered portion of the sutureless pump connector with your thumb and forefinger. Position the catheter port in line with the opening of the sutureless pump connector and attach the connector using one of the following methods. Firmly press the sutureless pump connector onto the catheter port until the connector fully covers the catheter port and the connector snaps into place. Or, firmly squeeze on the oval marks of the connector and carefully press the pump connector onto the catheter port until the connector fully covers the catheter port and snaps into place. Then, release your thumb and forefinger and check that the sutureless pump connector is properly attached by grasping the tapered portion of the connector and tugging as if to remove the connector from the pump. Also, rotate the sutureless pump connector 90 degrees to the right and left and feel for a correct, snug fit and that the catheter port isn't visible from any position.
When positioning the pump in the pocket, again, the side port, you want to make sure the side port does not rub against the iliac crest, the rib cage, and I tend to therefore rotate it in towards the midline.
Set 2 heavy, non-absorbable sutures in the fascia. The location of the sutures should roughly correspond to the location of the suture loops on the pump's perimeter. Pull one suture through each of the suture loops, and draw the pump into the pocket and tie the sutures. Be sure that the center reservoir fill port is facing outward, and that both pump ports are positioned away from the incision site. Next, carefully coil the excess catheter under the pump. Make sure that there are no kinks in the catheter, and that the catheter is away from the reservoir fill port and catheter access port to avoid puncture during refill and catheter access port procedures. Place 2 more sutures in the fascia. pull each one through a suture loop on the pump. Tie the sutures, securing the pump in the pocket. After the pump has been placed in the pocket, close all incisions using subcutaneous and skin sutures. Make sure that no sutures are placed directly over the reservoir fill port or the catheter access port. Apply appropriate dressings. Immediately following the implant procedure, program the pump with the priming bolus and the patient's prescription drug dose. Ideally, this will be done in the OR, so that all catheter and pump information is accurately entered into the programmer for future use. For detailed instructions on programming, please refer to the SynchroMed 2 programming guide.
The management of the common side effects for the pain includes restriction of activity for the first 12 to 24 hours and icing the wounds every 6 to 8 hours during that interval. A soft abdominal binder, not one that is restricting or limiting respiration, can also be used, and many patients find this helpful in minimizing extra movement of the abdominal cavity and of the incision.
To prevent postoperative complications, advise patients to stay in bed overnight. Staying flat reduces the occurrence of spinal headache. Patients can wear an abdominal binder or a tight foundation garment over the implant site to provide mild compression and reduce the chance of hematoma or seroma. Patients should monitor their incision sites for redness, swelling, tenderness, or drainage, and they should refrain from any exercise which flexes, extends, or twists the torso for 6 to 8 weeks following the surgery.
Have you sit up and demonstrate some of the other changes when you sit up. And here he is sitting up, and again you can see what's happened. The pump now has to be located about here, even though there look like there were other parts. If we try to move it over too far, here is the rib cage, and it'll be rubbing. Again, it's very important not to have the side port up. It will tend to rub against it. The same thing, this is very important not to let this rub against the ribs. So again, head towards the medial, angle it, and then the upper port. Again, down in here, there would have been a real problem had we made the incision here, because it's now in a skin crease that would not heal very well. And in this area, the pump has rotated. Over here is his his iliac crest, and again you have to be very careful that the pump doesn't rotate against the iliac crest. And if we mounted it on this side, again, the side port, you have to be very careful that the side port doesn't rub against the iliac crest. The other side is actually perfectly acceptable to mount it, but again the markings have to be on the same in the same manner. Special considerations for the pediatric patient: the pump has to fit in the space in the patient's abdomen, and when you have a very tight fit, it becomes crucial that the pump is rotated correctly. You want to make sure the side port or the tubing coming off the side port do not push against the rib cage, the iliac crest, because both of these can lead to either pain or to catheter fracture.
Clinical studies and surveys indicate that the rate of catheter-related complications associated with intrathecal drug delivery may be reduced by following specific surgical methods. The purpose of this segment is to demonstrate catheter complications that can occur and recommend methods that may lead to lower complication rates. The TUI needle insertion method for passing a catheter into the intrathecal space has included both midline and paramedian oblique approaches. In comparing the two methods, the paramedian oblique needle insertion technique is recommended because it causes fewer long-term catheter fractures and breaks. The midline needle placement technique is similar to a standard lumbar puncture. The needle passes between the spinous processes with the needle nearly perpendicular to the spinal canal. Because of the needle angle, the catheter must take a sharp bend as it exits the needle into the intrathecal space. This sharp bend can make advancement of the catheter difficult, and in some cases requires the implanting physician to make repeated needle punctures to advance the catheter. This creates multiple dural holes, increasing the likelihood of cerebrospinal fluid leakage. The sharp bend in the catheter can also make withdrawal of the guide wire difficult in a catheter that is placed using a midline needle technique. Even if the catheter is successfully inserted and the guide wire withdrawn, catheter placement between the lumbar spinous processes or ligaments can lead to catheter failure. Over time, the spinous processes and ligaments may compress or abrade the catheter due to friction or pressure. This creates another potential cause for catheter fractures and breaks at the level of the lumbodorsal fascia. A paramedian oblique needle placement technique offers several advantages over the midline technique. With a paramedian oblique placement, the site of needle entry through the skin is lateral to the spinous processes. The lateral coordinate for skin entry is parallel to the vertebral pedicle, approximately 1 to 2 centimeters off of midline. Entry is 1 to 1 1/2 vertebral levels below the interlaminar space through which the needle will pass, creating a shallow entry angle. The imaging target for the needle tip is the midline of the selected interlaminar space. The needle stylet should be kept in place during dural puncture with the beveled needle tip oriented parallel to the longitudinal dural fibers. A return of cerebrospinal fluid through the needle, even with the stylet in place, signals entry into the intrathecal space. With the paramedian oblique needle placement, a minimal bend in the catheter eases guide wire removal and decreases the chance that the catheter will be damaged or kinked at or near the entry site in the lumbodorsal fascia. Passage of the catheter through the paraspinous muscles for 1 to 1 1/2 vertebral levels before piercing the ligamentum flavum and dura may also help prevent catheter dislodgement from the spinal canal. Do not withdraw the catheter through the introducer needle. This can partially cut the catheter or completely shear off the catheter end. A partial cut can cause drug leakage, while a complete shear can leave a disconnected catheter segment in the intrathecal space. For more information on preventing catheter-related complications, consult your Medtronic representative.